Well, good afternoon, everyone. Thank you very much for making the effort to come in person through this truly, warmish weather today, to say the least. We appreciate your efforts. My name is Richard Downey. I confusingly work for our Africa program here at CSIS, but have latterly been drawn more and more into the work of our Global Health Policy Centre. Just by means of introduction, I want to give you a little bit of context and background to the work that this report that you hopefully have picked up on your way in is part of, and summarize a few of the main takeaways from the report. But before doing so, I'd like to acknowledge the support of the Bill and Melinda Gates Foundation, who supported this research effort, and also the collaboration that we've had here and benefited from with our excellent India program here, the Wadhwani Chair in US-India Studies. They've also been exploring the topic of innovation across several sectors, including health, through their US-India Innovation Forum, and I encourage you to look at the video cast of the other sessions they've had in that series. Finally, although he's not here today, but a shout out to him, my co-researcher and travel companion, Dean Garber, who helped in the writing of this report. When you travel together with work colleagues, you learn a lot about them, and so on a long road trip in West Bengal, I discovered that Dean suffers from terrible motion sickness. So the report that you see today is part of this broader project, and we've just concluded at the Global Health Policy Centre, examining some of the most important bilateral health relationships that the United States has around the world. Kind of some part historical exercise, tracing their evolution, assessing their accomplishments to date, but most importantly, considering the future course that they might take as these countries evolve very rapidly, how the US, as it engages, is evolving, and in trying to ensure that these relationships achieve maximum impact and relevance. So India was the fourth country, as I said, in this study. The other three that we looked at were South Africa, Ethiopia, and Nigeria, and you can see the reports that came out of those exercises on the Global Health Policy website. Obviously, four very, very different countries, and US relationships with each one of them follow their own unique course. But I think there are some interesting commonalities or parallels to highlight, just to put the study into a little bit of context. I mean, first and most obviously, they're all important regional and in the case of India, global partners of the United States, with shared interests that cover not only health, but a whole lot else besides. And also some contentious areas of dispute that are unique to each of the four countries. They're all countries that have undergone and are still undergoing rapid processes of development that with them have brought jarring health challenges. They're all grappling with growing and complex health burdens that include sort of combination of communicable disease, poor health linked to poverty, such as high maternal mortality and infant mortality ratios, and also this rising tide of non-communicable disease. They're all four countries that are struggling to bridge social inequalities that limit basic access to healthcare among the most disadvantaged groups. And they're all trying to address this, albeit in halting and incomplete ways, by setting sort of ambitious, even probably aspirational goals of universal health coverage, with the aim of taking the burden off individual patients who are still bearing the brunt of the cost of their own healthcare. All four countries are, while they're trying to work on this basic access issue, are also increasingly aware of the need to improve the quality of the health services that they're providing to their populations. And without belaboring the commonalities, one further one I would highlight is all four countries have incredibly complex governance structures. They're all federal or federated style systems. And that means there are multiple nodes of engagement for development actors to work with. And that can have pros and cons. What works in one area might not necessarily work in another, but in the case of Nigeria, for example, sort of growing exasperation with working with the federal government has actually led to some interesting initiatives at the subnational level. India, as I say, the final country that we looked at in this series, also provided an opportunity to explore some new themes, because there's some obvious and important distinctions between India that makes it the outlier, really, of the 4 countries that we looked at, not least because of its geography. First, the government-to-government part of the relationship between the 2 countries is a small overall part of the health relationships between US and India, much more than the other 3 countries. And the bilateral health relationship is set to shrink even more. I mean, India is already going through this transition from being a net recipient of assistance to a net provider of donor assistance. And it's a complex and incomplete transition that's exposing gaps in funding and coverage along the way. As total health expenditure in India as a proportion of GDP is only 4%, and the government share of that is a little over 1%, so quite small. Second, and on the more positive side, India has, I think, several advantages over the other countries we looked at. By virtue of its enormous size and the rapid pace of its development, it has a wealth of talent and resources to draw upon, offset, albeit, by the size of the needs that it faces as well. But India has so many talented medical professionals, medical researchers, scientists, a sophisticated and profitable pharmaceutical sector, and a thriving, although largely unregulated, private health sector for those who are able to pay for its services. India is also a hotbed of innovation and entrepreneurial activity to a degree that's really not present in the other 3 countries we looked at. I saw many examples firsthand of immensely skilled people who'd found new and interesting ways of delivering health services or health systems or health devices to people. What's lacking, I think, is some kind of robust ecosystem that can sort of channel these talents and direct them in a manner in which they can be most effective. So what does all this mean for how the US engages with India on health? Well, you can read more in the report, but as I mentioned, the US government's role, it may be small in dollar amounts, but from what we saw, it punches it above its weight in terms of impact, whether it's training epidemiologists or piloting healthcare innovations that the Indian government sort of takes on and expands, whether it's sort of helping to improve with India drug safety. I could go on. The US government also is an important convening authority that can bring together and try and coordinate somewhat the diverse health partners that are involved in India, from the pharmaceutical side to the non-governmental organizations, to philanthropic foundations, to academic institutions, diasporas, and so on. As I argue in the paper, the health relationship has never been a big ticket item in the overall US-India relationship, but I think it's a valuable component that warrants sustained attention. So it's unfortunate that our visit coincided with the release of initial budget proposals from the Trump administration that proposed to downscale what already is a fairly streamlined, slim operation. The proposal suggests proposes cutbacks of almost 45% in USAID's global health programs and 46% for those programs run by the Department of State. And given this context, I suggest that it's important for both countries to be vocal in emphasizing the successes of this engagement, point out that a lot of time and energy and upfront investment has been made in developing these partnerships, and that it really doesn't make strategic sense to draw back from them at this moment. But yet, given this, the likelihood of program cuts, It's also going to be important for the two countries to really sit down and agree upon their priorities and the things that they really value the most to work together on. And we list some of them in the report, and they include, I think, safeguarding progress in tackling communicable diseases like HIV and polio, where there's been so much progress, and that progress has been due in part to US investment and innovation. Another, I think, priority area is supporting India's ambitious plans to tackle TB, its most deadly disease. Maintaining disease surveillance assets and laboratories that can help identify emerging diseases of concern to both countries. And finally, deepening cooperation and technical assistance on drug regulation to ensure that Indian generic medicines distributed both in India and the United States are safe for consumers. But most of all, I think it's important to recognize the central place India must play in any effort to tackle disease globally. Fully 1/3 of the world's poor people live in India, has the highest number of TB cases, neonatal deaths. So India's size and the scale of its health challenges just demand attention and sustained investment. From a national health security perspective, it also makes sense to be working in India on issues like TB at source, because as we all know, TB cases here in the United States, India is one of the top 5 countries that are bringing cases of TB over. With that, I'll encourage you to read the report in more detail, and I'm going to turn the floor now to our guests, who are the real experts on these issues. We have 2 of them in the room, as you can see. One, Dr. Kyla Lasserson. I'll introduce her first. She's on the phone. It's an ungodly hour in Chennai, I think, where she is right now, and so we're very, very grateful that she's able to join us. You can read you have hopefully in front of you their detailed biographies, so I won't go into them now, but welcome to Dr. Lasserson. Next to me in the middle we have Dr. Betty Chang, who's Senior Director for Public Health and Medical Affairs, working in the Access Operations and Emerging Markets Group at Gilead Sciences. Thanks for joining us today. And then to my far left we have Dr. Alaya K. Nanda Kumar, but he said I can call him Nanda, so we'll save time that way. And Nanda is the Chief Economist at the Global Health Bureau with USAID. So delighted to have both of you with us here this afternoon. We're going to turn first to Dr. Lasserson to make a few opening remarks. Dr. Lasserson is the India Country Director with the CDC, and also the acting health attaché for Health and Human Services based in Delhi. So, Dr. Lasserson, first of all, can you hear us?
Yes. Can you hear me?
Wonderful, loud and clear. So that's a relief. So I got to allow you to make some opening remarks.
To look at about 25,000 individuals with either fever or encephalitis, and through that work actually identified that across the entire country there are only 7 pathogens that are the most prevalent pathogens are consistent across all of the entire country, and those include dengue, influenza, Japanese encephalitis, leptospira, malaria, and scrub typhus, and cancer forest disease, which is a tick-borne viral disease in some parts of the South. And through that knowledge, which really wasn't known until we started this work, we were able to recommend to the program that these sorts of diagnostics need to move down into the district level. And by doing that, we can diagnose about 85% of the pathogens causing fever or acute encephalitis that can be diagnosed. So that's underway at the moment. We've also, through Global Health Security, been able to strengthen all the laboratories throughout the entire country at the district and state level. So looking at gaps within microbiology, within basic pathology, and then finding those gaps, providing mentoring and training, and strengthening the entire lab network. So that's been another product of the Global Health Security agenda. And then the other large area that's very important is antimicrobial resistance, which includes multi-drug resistant TB as part of that, with a kind of an epicenter of multi-drug resistant TB in Mumbai. But the antimicrobial resistance work has included working with 2 national networks that span the country and beginning to look at antimicrobial use, beginning to look at improving infection control and prevention, looking at hospital-acquired infections, and strengthening the laboratory surveillance of antimicrobial resistant pathogens. And then the final area that's been an enormous push through Global Health Security is looking at the public health workforce and training in epidemiology. We, together with the government, started an India EIS program, which is modeled on the CDC EIS program that many probably in the room are aware of, which is a very field-based, hands-on epidemiology teaching how to investigate outbreaks, how to do epidemiologic studies. And through that collaboration, we've been able to reach out to the district, state, and national level, teaching epidemiology and teaching young doctors how to investigate disease. And one particular success story has been there was a long-term situation of acute encephalopathy in children in Bihar, in the state of Bihar. Many children dying every year from this, and an unknown, considered a mystery illness for many, many years. And through using this epidemic intelligence service, these officers, and using this respond, detect, prevent framework, we were able to identify that the pathogen was actually a toxin from the lychees, which are grown in that region. And by eating those lychees, the children who are largely malnourished in that area, they weren't eating an evening meal, and the combination of not eating dinner and having this toxin, the naturally occurring toxin from the lychees, led to this very high mortality. Identification of that led to recommendations to minimize the consumption of lychees and to have an evening meal. And now this last season, there was only about 20-30 cases. So that's actually been a real success story of the program, but also Global Health Security. So we're trying to scale that up with the government across the entire country, including also short-term epidemiology training. Building that public health workforce is a critically important piece of Global Health Security. So I'll stop there, but I think that just to say that this has just taken off really in the last year and a half, and we're really hoping to be able to continue working with the government as they take on more and more ownership of Global Health Security and some of these specific activities, so that they have a sustained public health response and a preparedness for whatever pathogen may come along in the future. So let me stop there, and then of course I'm happy to take any questions. Again, thank you for inviting me.
Thank you very much, Kyla, and thanks for those really good examples as well that you gave us. Betty, let's turn to you and hear from Gilead about the kind of partnerships that you've managed to forge in India.
Sure, thank you, Richard, for having me here. So for Gilead Sciences, it's been a long, over 10-year partnership investment working with India. You know, when we came out with life-saving drugs for HIV, you cannot ignore that the bulk of the disease burden is actually outside of the United States and Europe, where most of the burden is in Africa and Southeast Asia. So we were very naive when we first developed these innovative drugs because we thought, well, let's do our part and offer it to these countries at the cost of goods so that, you know, they would be able to have access to our products. And you soon learn that it's great that you're offering these products, but it's still outside the means of affordability for patients in these countries. So over time in the last 10 years, our group has really evolved and changed our approach because you have to. You have to find innovative solutions to meet the needs of, in order to make products affordable for patients who may not have the means of being able to purchase. So for us in 2006, when we had our approaches, we sent our FDA dossiers to all of these countries thinking that, okay, we'll register the products. Well, every country has their own regulatory process. So in doing so, we realized that not only do we have to be fully involved in these countries, but we also had to find a way of reducing the cost of these products. So we were one of the first companies to give our tenofovir to the medicine patent pool, and this allowed generic partners to be able to license with Gilead and the medicine patent pool to make these products more affordable. So even though our products in the US perspective was not that expensive compared to what the US is paying, this is still very high. So for example, we would be able to provide tenofovir at $17 a bottle. The Indian generic companies, through technology, they're great at manufacturing, they were able to bring the cost down below $3.50 a bottle. So by finding innovative ways to reduce the costs, you're better able to meet the demand. So now there's over 10 million patients on tenofovir-based regimens. So we are always providing, we learned a lot of lessons from our HIV endeavors so that when we went into hepatitis, we didn't wait for the US to get approval. 2 or 3 years before the actual US approval, we were already working with the medicine patent pool and the generic companies and signing licenses so that they can start working on these products way ahead of time. So by signing a license, you provide the technology on how to manufacture these products. This allows them to ramp up and be prepared so that when they get approval, the products will be readily available there as soon as approval happens. You don't want to wait till approval happens with the branded product and then they have to wait and manufacture. If they had to do it on their own, they would have to invest funds into R&D. It would take them twice as long, instead of a year, probably 2 years, to do reverse engineering to produce the product. And it may or may not be made in the exact same way as how we manufacture. So there should be harmonization because patients across the world deserve to be on top quality medication if the technology is there. So, you know, when I go to India, it's a partnership. I go there, meeting up with the generic companies, and we not only provide the technology, but what comes with that is that we invest in public health. Because if you have scientific innovation, you also, that's not enough in and of itself just to make the medication. You also have to invest in the implementation and the public health and strengthening the infrastructures in these countries. We register our products in India. We provide the clinical data. The Indian generic companies are able to do bioequivalence studies and get their products approved right away. Oftentimes, in my experience, India's products are there first before even Gilead's products are available in India. So the key importance of that, even though hepatitis, by numbers, it's quite high in India. By percentage, it's quite low, but as you know, India has a large population. But in doing so, they also provide the product for the rest of the developing world. So if you look at the PEPFAR projects, they rely heavily on our Indian generic partners, and they go through FDA tentative review so that, you know, they're getting a stringent regulatory authority approvals to assure that quality products are going out to the rest of the world as well.
Great, thank you very much, Betty. Nanda, over to you.
Thank you. Dr. Kayla, first of all, I just wanted to thank you for staying up so late to take part in this. And Richard, thanks for having me here. And I strongly encourage everyone to read the report. It's an extremely well done report. And What I wanted to spend a few times on was building on the theme of how vibrant, right, the Indian healthcare market is, and the appetite for innovation, and how, as USAID, I wanted to share some of what we are trying to do, right, to shape these markets. Just as background, right, as the report also mentions, India has one of the fastest growing economies in the world, right? And there are some estimates that show that over the next decade, investment in the health sector in India will increase by about 400%. But the unfortunate thing is that if you dig a little deeper, the bulk of this is going to go into secondary and tertiary care and not necessarily in the primary care markets where you get the highest health gains. Now, India's urban poor or near poor populations are expected to touch 600 million people by 2031, okay? And this segment is increasing at 5% per annum. And compare this with the rate of growth of rural populations, which is at 2% per annum. So this is one of the fastest growing population segments in the country. If you look at urban India, 75% of the health facilities are owned by the private sector. 80% of all outpatient care and the vast majority of inpatient treatment is sought in the private sector. And yet, when you look at where the money for private sector this care is coming from, 85% of this is financed through out-of-pocket spending. Okay? So again, the other context is, so there's an incredible burden, right, on out-of-pocket spending, which creates a lot of inequities when it comes to the poor and near poor populations. If you look at insurance products in India, they typically only cover inpatient care. They don't cover outpatient care because the outpatient care market is not stable enough and predictable enough where insurers can go in and offer a product that will cover outpatient and inpatient care. And from our perspective, if you look at the urban population, only 9% of the population that we want to focus on, the poor and near poor, have any kind of insurance whatsoever. Okay. So when we looked at this market, we found two things. One, there was a strong political will on the part of the government to improve the health of the urban poor. So there was this political commitment. And at the other side, we found that all the elements that should make a market function were there. But nobody had actually figured out how to put the elements together and incentivize, right, investors to come in and invest more in the primary healthcare market as opposed to secondary and tertiary care. So we took this problem, but given India's size, Richard, as you rightly pointed, we wanted to make it more manageable from our perspective. And so we posed a question for ourselves. Can we cover by 2020 10 million urban poor and near poor, right, through scaled, quality, affordable, private primary care networks? Okay, all these words are very important. And by doing so, reduce the burden of out-of-pocket spending for these segments of the population by 30%. So this was the problem we set out to solve, and we had about $10 million to put behind it. And just to put this in perspective, even though India spends very little on health, just the budget increase, the delta in the government budget was billions of dollars, and we had $10 million. Okay. So what does one go in and do? When we looked at this assessment, we realized that what we needed was about $150 million to make this work. So we went in with 10 million. We could have done a more traditional grant system where we go in and give grants for the 10 million, but we decided that was just not going to work. So our approach has been much more innovative, right? We are using inclusive business models. We want to leverage domestic capital, right, into the primary care sector. We want to engage the communities. We want to build the management capacity to go to scale. We want to deploy innovative solutions, right, where we can make this work. So the real question was, can we bring all these things together as USAID and the US government to demonstrate that the private primary care markets are viable and can be made to function. We've been at this for a couple of years, and we are seeing a lot of enthusiasm and success, right? But what it has meant is that we have had to do things differently from what we traditionally do. We have to be much more strategic, much more focused, right? But there's a tremendous appetite for innovation, and there's a tremendous desire from the community to pay for affordable care. What is happening now is when you create a platform which potentially will have 10 million people with predictable costs, quality networks, we have now, the next step is we have been approached to see whether we can leverage this platform to help the country think through what the next generation of the health insurance products in India should be. Can we have an insurance product that has both outpatient care and inpatient care? For us, this kind of transformative change, where you can use a little bit of money to make changes at scale that can then lead to the reorganization of urban health markets, is really exciting. Thank you.
Thank you very much, and thanks to all three of you for some starting us off with some excellent examples of innovative partnerships in healthcare. I have a couple of questions maybe to kick us off, but I wanted to spend most of our time that we have this afternoon opening the floor to everyone here to pitch into the conversation. But maybe I could ask something to start us off, and I think maybe this question is primarily directed to you, Nanda, and to Kyla on the line as well, but don't worry, Betty, I'll have one for you as well. But, I mean, and it's this argument that, of course, India is now a lower middle income country officially, and therefore, one can argue that it does have the resources to deal with its health problems. Yet the needs, as you've all outlined in different ways, are enormous. What's the case sort of to be made domestically here about the importance of continuing support to India? And as you've said, it doesn't have to be in monetary support necessarily. What other kinds of support are most important and most valued, do you think, in your engagements with India? Maybe I'll start with Kyla, and then Nanda, you can add to it.
I can add to it. Thanks.
Sure. Thank you. So I think I think just the whole kind of building up the preparedness infrastructures, the increased detection of disease, the specimen transport, the quicker response, the investigation of risk factors. What we're providing mostly for that is technical support, experience that we bring to bear on that. And I think by doing that, we're going to keep the pathogens, whatever pathogens, in India, and they're not going to move. And I think that argument is really important because we obviously saw with Ebola the importance of building the infrastructure in country to be able to contain Ebola in West Africa. So I think that the argument is to really ensure that the structures and the know-how is in place in India to contain whatever pathogens, including TB and drug-resistant TB as well. So I think that argument is fairly straightforward, and that's the kind of work that we're doing. And it's not that it's the financial investment as much as it is the technical investment and the collaboration to build that sort of general preparedness.
Thank you. Thanks, Nanda.
Yeah, I completely agree with Dr. Kayla. And I also just wanted to add that, as the report also points out, if you were to tackle in a more strategic way and help the government of India, not we tackle, but help the government of India tackle in a more strategic way, in a more effective way, it's the burden of disease and health, you could bring down the mortality rates by 20 and 25%. So it's not, India is a very interesting country. It's making a lot of economic progress, but there's a lot of health burden and health inequities. And we should not forget that 3 in 10 Indians still live below the poverty line, right? So there's a huge unfinished agenda. There's a tremendous amount of enthusiasm on the part of the government to tackle this agenda and take on this agenda. So the real question is, from our perspective, as Dr. Kayla mentioned, we need to engage, it is not so much our money, but it's the technical expertise It is the global health diplomacy we bring to the table, right? It is creating market-based solutions that are going to achieve these changes. It is providing that kind of help, that is important. And just as a point of reference, for every dollar that we might invest from the US government, we are freeing up, or we are leveraging up to $5 of philanthropic investments in India, right? And we have the potential, right, to unlock about $10 to $20 of government resources, right? So from an economist's perspective, the return on investment is a no-brainer, right? But it is what we do and how we do it that becomes more important than purely the dollar amounts of money that we would have to put in. And as you rightly point out, if you want to, India has the potential to be a game changer, not just within the Indian context, but what it does globally. And as you were rightly mentioning about this whole generic pharmaceutical industry growing, the IT sector growing. So the positive externalities of investing in India are immense.
Thank you. Turning to you, Betsy, you gave us a sort of thumbnail sketch of Gilead's history of work on HIV in India, and then touched on more recently the Gilead's work on hepatitis C. I was wondering if you could expand on that a little bit and explain how this partnership has been working. And I think you have more than 10 or so voluntary licenses with Indian generics companies in India, and how what impact is that having on prices? And I know that there's been a recent effort by one state in particular to introduce free hepatitis C treatment, and maybe as a sort of a pilot project, explain how that's going and what the potential implications are, perhaps nationwide in India, but also for other countries as well as they kind of tackle or look to tackle hepatitis C.
So I think Punjab is a great example where the provincial government took upon offering free medication. I think that when you make the product affordable, it's not so daunting for government to actually provide care for its patients. If you create some value where they said, actually given the number of patients we have here, we can afford to take on giving free medications to patients. And then they partner with the generic companies. It's not just the medication, you actually need diagnostics as well in order to diagnose this. So we have organizations like CHAI and FIND that are committed to making this affordable and how to implement this in region. So by Punjab doing this, it spread to the other states, and I think Haryana is also looking into this. And I think that where there's significant burden, I think in Punjab it's about 3%, some numbers are quoted higher, you can't ignore this problem. It is significant that by waiting for patients to get ill with cancer and cirrhosis, they're burdening the healthcare system. So by tackling something that's only 8 to 12 weeks of treatment, you're actually, from a public health perspective, saving money on not spending so much resources on these patients towards the end of life. So I think that that's upon us in the public health sector to show a value of how we can work with them and strengthen their healthcare system and not wait for a disaster to happen before you invest time. Another organization that was in your report was in West Bengal, and this is Dr. Abhijit Chowdhury. I've known him for many years, and I remember sitting with him at a liver conference where he discussed his concept of building this liver center in an area that had a lot of liver disease but did not have the facility to manage these patients. And this was a dream for him. And he asked for Gilead to support him by putting an investment in starting the startup funds to build this center. And we only were a partial funder, about 20, I think ultimately 40% of building it. But he had outside investments. When we're willing to invest in an important project, other funders will come. Sometimes you just need to be the first one to put in the funds to help it happen. And I'm happy to say last year he had an opening with great success, and his model is a scale-up. So he has facilities for those who can afford, and they sort of subsidize those who cannot. So those who are actually without means, they will have ability to get liver care at this hospital. So he had an innovative solution to tackle the problem of how do you provide health care to patients in West Bengal that serves the economic status of all the patients in the region. So.
Yeah, you remind me of one of the highlights of the trip. Actually, we went to look at that facility and saw the original investment and the way that it's been, extra levels have been added onto the facility, and it's truly an impressive site. And Dr. Chowdhury is a good example of innovation in India, and a kind of ambitious guy who's showing us the plot of land and his plans to expand yet further. So, very, very impressive work that he was doing there. I'd like to open the floor to questions now. Let's take 2 or 3 at a time. If you could introduce yourselves, and if you have someone particular you're directing the question at, please do so. Otherwise, we'll allow each of the panelists to contribute as they see fit. Let's start with you. You were first with your hand, so let's. The microphone is coming as well, so please use that.
Excuse me. My name is Chris Winger. I've worked extensively in public-private partnerships. I'm currently a consultant in the area. My question is directed to Betty. What does Gilead get out of its work? Is this just CSR, or is there more out of it? And the reason I ask is because I think a lot of the really exciting PPPs, you get sustainable health work, and if I could understand what Gilead gets out of it, we might be able to go talk to other pharmaceutical companies and get them doing similar types of work. So I'm interested in what Gilead gets out of its work. And I haven't read the report. It might be in there. I apologize in advance if you're just repeating. Thank you.
No, it's not in there, so thanks for asking. Yes, let's go to, yes, that's right.
Hi, my name is Claire Wingfield. I'm with PATH, an international NGO based here in the States. We do product development, and we have a lot of partners in India, manufacturing partners, research partners, work with the government. And one of our biggest challenges, I think, in product development and health innovation is the regulatory system. And Dr. Lerson talked about infrastructure for surveillance, but the regulatory system is also critical. And so when we have to, having to turn to other stringent regulatory authorities, I'm just wondering about the investments and what the US could do to help strengthen the regulatory system.
Thank you. Let's take one more, and then we'll come back for another round. Let's come to the front here, Nellie.
Hi, I'm Nellie Bristol with the Global Health Policy Center here at CSIS. And so I wanted to get some comments from you, Nanda, and maybe Kayla, about how global health security and universal health coverage, sort of the 2 themes you talked about from your agencies, how they support each other and how they could mesh a little better.
Thank you. Well, let's start, Betty, why don't we start with you, and the first question was directed to you.
So I think what started out as a CSR effort, a lot of companies, not just Gilead, have CSR approaches and business model approaches. So I think our approach evolved over time. I wanted to highlight, you have to learn from your mistakes, that when you started and you say, hey, okay, I'm going to give you cost of good at COGS, that's very naive, right? Because you're not really applying what's realistic in these countries to make it really happen. So, but I think for Gilead, if your HIV had a lot of attention, you cannot operate in this world of HIV without finding global solutions, because you can't work in silos. And it's the same true for any business. If you're working in that arena, you have to take into account the rest of the world and the burden there. I think what we try to do in our Access Operation Emerging Market is create a sustainable business model. Because if we want it to have longevity, because CSR is nice, but then when a company is not doing well or not well, it changes the funding to what it will donate towards that. But if you create a sustainable business model, it has a life of its own, and it's more sustainable for the long term. And so far, this has been ongoing for 10 years. So I think that when you have the amount of burden that you have in Africa, that's a large amount of medication to produce. We're innovative in developing innovative products, but manufacturing, the Indian generics are top notch. They know how to get costs down, production lines, high volume. So you want to partner with people who do what they do best and can meet the needs. Now, someone brought up regulatory. That's an excellent point, and it's one I spent a lot of time with, because if regulatory processes are burdensome, and you have to understand in Africa, not every country has ability to review these dossiers in detail. So working with Gates and WHO, they've developed a pre-qualification to provide SRA so that there could be approval. We need more funding towards this and advancements, because that could be a bottleneck to getting patients on product. Delaying a year or two is a dramatic number of lives at stake that are not getting access to life-saving medication. So that's why our Gilead cannot just transfer these licenses. We actually have to, we hired a lot of regulatory people in Gilead to work on the rest of the world where they actually file, and every dossier is specific to country. Well, we would love to see more innovation, like in Africa, with one regulatory process. File with one and get regulatory approvals in all of Africa. Why do we have to do it individually with each country and do 50+ registrations? So I think that's absolutely an excellent area.
Thanks. Just a sideline on the CSR, the law that was passed in India requiring Indian companies to contribute, I think, is it 2%?
2%.
It provides some interesting openings for Indian companies and perhaps some interesting partnerships there from other countries and companies who are used to sort of thinking about CSR and not that there are some very forward-leaning Indian companies as well, but there's some interesting partnerships developing on that front and opportunities. Sorry to interject. Kyla, maybe you'd like to come in next.
Sure. I think the ways in which global health security would intersect with universal health coverage probably are in the areas of diagnostics. I think one of the important discoveries that we've learned through all the global health security work is how little sort of case-based surveillance there is throughout the country, and how few laboratories really have an array of diagnostics. So I think getting those diagnostics at the district and state level lead to, of course, the diagnosis of the right pathogen and then better care. So that's true for generally. I think then we're seeing that also specifically with MDR-TB. Part of the global health security work is increasing diagnostics and good drug susceptibility testing for TB drugs, and that's also affecting care. And as well, as part of the MDR work, we're looking at adherence models and best practices and what's the best way to keep people on treatment and lead to a cure. And then I think finally, within the antimicrobial resistance, all of that work, it's a critically important area for general, health coverage and health care, is to have to prevent to take care of the antimicrobial resistance that's there and to prevent more from developing. So I think all of those areas, though not specifically universal health care coverage, certainly intersect with it.
Thank you. Nanda, do you want to add something?
I couldn't agree more again. So couple of quick comments, right? So I think at the start, Richard, when you mentioned that, I think what needs to be created is the appropriate ecosystem in which innovation can take place, right? And to your point, I think it's this whole regulatory environment. How can you don't want to loosen it too much, but you don't want to tighten it too much, right? So what's the right balance between, too much regulation, too little regulation, that would help innovation succeed, is an area, I think, where there is growing interest, and an area where I think this is exactly the kinds of areas where I think the U.S. government has the knowledge and the expertise to engage more proactively. So that's a point well taken. And just to build on what Dr. Kyla was saying, I think if you look at, again, each one of us approaches things from our own discipline, right? So if you look at health markets and you talk about universal health coverage, there are three different kinds of products in a health system, right? The public goods, and then you have the private goods, where the public goods are goods that you cannot divide it, like it's clean air. If I breathe clean air, I can't say you're not going to breathe clean air, right? And then private goods are where the benefit goes primarily to the individual. Then in the middle is this very interesting piece of what we call merit goods, where the benefit to society exceeds the benefit to individuals. Right? So a lot of things we talk about, immunization coverage or TB treatment or having safe deliveries, falls within this little, this bucket, correct, where society feels that people should consume more of this and people left to themselves will consume less of this. You cannot achieve universal health coverage unless you tackle all three markets of products and goods that you find in a healthcare system. Right? So what is done under Global Health Security Agenda in terms of strengthening, correct, the infrastructure and the system to deal with the detection and treatment of things that we may consider to be largely merit goods, right, where the benefit to society is huge from doing that, has to be integral to the overall construct of any universal health coverage. So to me, I don't see any disconnect or dissonance of how you do it. Now, when you talk of universal health coverage, then you talk, in addition to this building the infrastructure, you then talk about access, the financing, the incentives. So, it's putting all the pieces together that can lead to access to care, especially where we are interested in is the poor and the near poor and vulnerable populations. And all studies have shown the rich do quite well, thank you, irrespective of where they live. The real thing is, how do you get to the poor and the marginalized populations? And I think that's where I think these things kind of come together nicely.
Thank you. Let's take another round of questions, and a gentleman towards the back has his hand up. Let's start with you, sir.
Yeah, thanks very much. Kami Arkajavi, USAID, Global Health. Comment and a question. So the comment is just to build on what Kayla Ananda said about the relationship between UHC and health security. So the other link there, I think, is resilience. So UHC is a good entree into developing health systems, and in the event of an outbreak, strong health systems, as we saw in West Africa, might prevent sort of disaster from happening. The question actually that I have is for Betty. If you are selling, if you're giving away drugs essentially, or giving your patent to a drug to be sold into a very poor country, you probably do things to keep those drugs from flowing back into your regular markets. In this day and age now where, in a place like India, half the people are very poor and a good number of people are actually very rich, how do you do business there in a way that allows you to provide the drugs to the poor, but at the same time preserve the market that you might have for the rich?
So in India, we do it for the same. We provide, the example I'll give is for our Hep C drug, because it's gotten a lot of attention. We actually provide one price. We don't gear it towards any population, or it's part of the 101 countries as part of our access model. So we know all we've done in that situation in India is reduce the cost of the wealthy from coming to the US and purchasing it at the US price. But the benefit for the larger population, which is what we're more interested in, is those in the lower economic status. It washes out in the end, because the intent is to do public health good and to increase the numbers to as many people as possible. It's very contradictory. Sometimes our distributors are not very happy with our branded products, because we will say to them, they would like to sell it at more, and we would say, no, we actually would like to cost reduce our product, because if you can sell only this much at this higher price and you reduce it, you're going to impact so many more patients. And in the end, how my group gets measured is the amount of lives that are improved and impacted have access to our product. So I think that by devoting this model, you will actually reach more people, and that's the ultimate goal, is the number of people.
Let's take a question from you, lady at the front. There's a microphone on its way. We'll take you next as well. Thank you.
Hello. My name is Dr. Elvira Barracochia. I'm with Realizing Global Health, and thank you very much for your presentations today. My question is for Richard and for everybody on the panel. I'm trying to understand how the U.S. strategy for India is evolving as the country approaches, hopefully, graduation. And I see that Kayla is working to strengthen the disease surveillance in the public sector. And Dr. Nandakumar, you're working to strengthen the private sector. What are the other pieces, and what are the main metrics that will show that we are really impacting those areas that really will help us save lives? Thank you.
Thank you. And let's take a question from you. Thanks.
Hi, my name is Aiza Isaac, and I'm an intern from UNAIDS. And my question is, what kind of alternative partnerships do you see developing in India to take on infectious diseases like HIV and AIDS, which have the stigma associated with them? Do you see faith-based organizations, or largely like is it a domestic thing? I'd like to know more about that. And my second question is directed towards Dr. Nanda Kumar, which is that you've mentioned that there's great economic inequality in India, and that one of the advantages of India is its sheer scale. But in the past cases, USAID has taken an approach where it's pooled demand to access medicine, purchase medicine, which was previously inaccessible to a lot of people. So I'm wondering, why has that not occurred in India's case? Thank you.
Thank you. Great, some good questions there. Should we start with Kyla, if you're still hearing us, and perhaps you could address the first question about, so you're probably best placed to do so, particularly the question about the overall US strategy on health in India, and the metrics that are being used to sort of gauge progress and transition.
So that's a great question. I think, I think we're kind of globally struggling with some of the indicators for impact for global health security. There's a desire to look at some of the process indicators, the number of people trained, or the number of laboratories that have these diagnostics or that have been assessed and that sort of thing. But we're really beginning to try and move into, lives saved, time to diagnosis, outbreaks investigated, morbidity and mortality measures. So those are the sorts of impact indicators that we're looking at, and to be honest, we're all kind of developing them as we sail the ship, because global health security is relatively new. And so I think, we won't necessarily know that we're there yet, because we're still building those indicators, but definitely when we can detect an outbreak faster and get people diagnosed and out of a hospital setting faster, and reduce, as we did with the lychee example, drastically reduce mortality and morbidity, then those are the sort of indicators and impact that we're expecting. So it's fairly straightforward public health indicators for the global health security impact and what we're measuring. But it's still, really being designed, actually. So it's an important question.
Thanks. Maybe I'll just to continue the theme and talk a little bit about transition. That was an issue that we highlighted in the report as being something that requires careful monitoring, and there's an importance to be sort of slow and steady in that process, because yes, India is now a lower middle income country, but also it has had a lot of traditional support from the Global Fund, for example, which is sort of facing a quite sharp drop-off down to zero in the next sort of 10 years. And obviously PEPFAR money is a very fairly small amount, but it's not really about the dollar amounts, as we've said before. It's the technical assistance and the mentoring, and so as that support tails off, it'll be very important to closely monitor and plan out that process. But so just adding on to Kyla's point there. But either of you two would like to add to the other questions that were asked?
No, I think one of the things that we are learning, and Richard, this goes to your point and something you alluded to, is in terms of donor assistance, what is needed is a glide path, right, as countries go through economic transition. And some of the work that we have been doing is very interesting. It's been more in the African context than in the Indian context. And I just wanted to share, share something. And what we've been looking at, what happens in the context of economic growth and transition, right? So if you look at around 1993, there were only 3 countries in Africa where donor spending on health exceeded public spending on health. By 2010, there were 17 countries where donor spending on health exceeded public spending on health. Donor spending as a share of total health spending went from 13% to 39%. Okay. Now that's not the real story here, right? What happened was that when countries transitioned from low income to low middle income, for those countries, donor spending as a share of total health spending dropped to 9%. Right? But what happens is as countries get richer, they spend more on health, and that's what we call the first law of health economics that holds always. So what had happened was that we were pulling back way too quickly. We pulled back way too quickly. Health spending has gone up. Because of our presence, countries were not investing as much. And what we started observing was a significant uptick in the burden of out-of-pocket spending. So inequities got exacerbated. So I think, when you approach a country like India and say, what should we be doing, right? What we are trying to figure out, and as Dr. Kaila mentioned rightly, is what is, you need a glide path to engagement, but even as we are on the glide path, we have to do different things. We cannot do what we were doing 50 years ago today, and we certainly won't be doing what we're doing today 10 years out, right? And so it's really trying to be more responsive to the needs of the country and identifying those specific areas where we can bring value add that the country wants us to contribute to. Correct? It's much more doing that and trying to shape, correct, certain and shape certain policies that would lead to more optimal outcomes. Right? So I think that's not always easy, and it's something that, as Dr. Kaila mentioned, we are trying to figure out as we are sailing the ship.
And from Gilead's perspective, advocacy is very important. We try to partner with groups that are very passionate about serving stigmatized groups. One that comes to mind is YRG Care. They spent a lot of time treating patients with HIV, and they really pioneered outreach to all the regions, reducing cost. We have a MOU with Tata Trust now, where they're going to take part of the CSR fund, encourage other corporations to provide CSR money to 2% towards healthcare that's not covered. So I think trying to find innovative approaches within this ecosystem of what they have is one of the best ways to start momentum.
And I think there was another question about why are certain things not being done. I think the reality of the situation is that we should understand that as donors, what we bring to the table is a rounding error on the health spend in a country like India, right? When you talk about 10 million, 20 million, 30 million, right? So our strength is not so much the money, but the voice we can bring to the table and the more strategic engagements we can. But at the end of the day, these are countries that are going to make their own decisions, right? And what we can do is facilitate a dialogue, but we cannot impose solutions, right? So and this is something that, from a development assistance perspective, for those of you from India, we always say there are two ways to approach enlightenment. One is to say, I am the Brahman, and then you become so big that you become one with the universe. The other thing is to say, I am very small. So, all the humility can lead to enlightenment, or expansive, thing can lead to. I think when you go to India, the former is better than the latter.
Thank you. Let's take some more questions. And the lady in the middle there has one.
Hi, my name is Rachel Green. I'm a graduate student at Georgetown University. I just wanted to ask if you could point to specific examples of tech or skills or anything that you've learned from the GHSA experience in India that is translated to the US experience right now, so problems that domestic healthcare providers are facing, and just if you could draw that link, that would be great. Thank you.
Thank you. Interesting question. Who else has a lady at the front here has a question as well?
Thank you very much. My name is Shashi Shrivastava. My question is, what are you, so for example, if I am interested in education to prevent disease, what help can I get from a panel like you, and what are you doing to provide good health by giving them education so that they can make their own innovations by the end of when they are healthy and they can think straight? I think they are quite capable of doing their own innovations.
Yeah.
So what is the plan for this? Thank you.
Thank you. And I think, yes, the gentleman there had a question as well.
Thank you. I'm not sure if this question fits in this panel discussion, but I'm Ranjan Gupta from NIH. I just wanted to ask, so, India is, as we always speak of India, there's a two-tier. There's the masses of poor people, and, you're trying to reach out to help them with healthcare. And then there's the affluent people who is a different tier, like a developed world. What I've heard from many people in India is that with the advent of healthcare, insurance companies, etc., the people who do afford that kind of healthcare system, that there's also a high rise in medical malpractice, that knowing that someone has insurance prompts medical establishments to charge them more, sometimes treat them for things they are not supposed to be treated, and many other even adverse situations. And I was talking to someone else from a different country who was they were also trying to implement their healthcare, and they pointed out they went through exactly the same phase. Like in the initial phase when insurances are built and this infrastructure, this is a very common situation. So I guess even the United States may have gone through similar phases. Is there some lessons that are learned here that can be taught or implemented or at least advised to the government for best practices? I just thought I'll ask that.
Great. Well, that's one for you, I think.
I think I'll start with that question. I think this is exactly where you hit the nail on the head, right? We have walked this walk, right? And most developed countries have taken decades to figure out, if you talk to the UK, even the NHS has taken a long time to figure out, and we continue to figure out what to do. Now, when it comes to insurance, what does insurance do? It makes the insured, that is the consumer, price insensitive, right? And therefore, it creates in the environment where oversupply of healthcare services is tolerated because you feel I've already paid for it, and I'm more than happy to get more services. But insurance is not just the payment, right? It's the strategic purchasing. And how do you use strategic purchasing to create the right incentives so that the health providers are working to the interests of the consumer and not the other way around, right? And this is an area that we have learned quite a bit and we know quite a bit about, right? Whether it's Medicare or private insurance or Medicaid. And this is exactly the kind of knowledge, correct, that we could transfer and telescope, right? The time that India will take. We don't want India to take 50 years to figure it out like we did. Can we do this in 10 years for them, right? What has happened because of this, exactly what you mentioned, the products in India are like indemnity products. You buy insurance for $10,000 or $20,000. When you go to a healthcare facility, they know you have $20,000 and they will bill you for $20,000, right? So no one's making any money on health products either. So it's how do you get this insurance market to function like an insurance market? And we have learned it the hard way. And you actually, this is exactly the question to ask, this is exactly the kind of learning that we can transfer not just from government to government, but we now with the markets opening up, our insurance companies can go there and transfer that knowledge. Medicare can help transfer that knowledge to the Indian health market. This is where the tremendous value add. This is not about money. It's about knowledge transfer and technical assistance.
Thank you. Let's turn to Kyla to jump in on any of the questions that she would like to address. Maybe particularly the first one about the sort of the technological, the skills, learnings from GHSA and whether they're applicable here in the US.
Sure, thank you. That's a great question. I think probably the areas that we're finding with our US CDC colleagues that are most relevant to kind of bring back to the U.S. probably fall in the area of the antimicrobial resistance, how to measure hospital-acquired infections. And of course, we're doing that in the U.S. also, but there's quite a lot of issues that we're seeing in India that we can bring to the U.S. examples, the best practices for infection prevention and control. I mean, it's really a two-way street, as well as some of the data systems and the data movement. Really, it's very difficult anywhere to find data systems that talk to each other, different disease surveillance systems that link. So some of the work that we can create in India and elsewhere, we can also bring to the U.S. I think it's also true for outbreak investigations and best practices. So because all of this really comes down to the best way to practice public health, and because the burden of disease is so great in India, the practice and the various examples and the private-public links, and also the animal-human sector, sort of intersectoral coordination is also happening in India and elsewhere. And all of those are very important for the U.S., where it also hasn't been solved or completely figured out. So I think it's really going both ways in those areas. And it's been really a fruitful collaboration that way, because we're all sort of learning together. And you know, we saw with Ebola that the U.S. was also not ready. And so, it's really important learning across all countries in this global health security. So it's many of the lessons that we're learning in India are applied in the U.S. And elsewhere.
Thank you. Bessie, is there anything you'd like to add?
So, and I think, like most companies, we do have a grants program separate from my group. And I know Gilead has supported a lot of innovative projects specifically to India. Besides the West Bengal Hospital, we've supported ECHO programs, which started in the U.S. and University of New Mexico as an outreach program to train outside of the city to get to rural areas in the United States and provide specialty training, when it normally would have taken patients 2 or 3 hours to drive in to see physicians in academic centers. So, you know, India professors had the same approach. We're working with Professor Shiv Sarin at ILBS, the Institute of Liver and Biliary Disease, and he actually created an ECHO program where he networks with other academic institutions in India, training them on the latest technology for liver disease. And he extended it beyond physicians to nurses, educators, and health extenders. And, you know, technology is quite a powerful thing, that knowledge is out there. And I think that in order to combat erroneous care, you know, that information is out there in India, and patients are getting smarter and smarter, where they're looking up how to manage things. So I think getting knowledge about correct ways of managing cases, it could be overwhelming, but it also could serve as a powerful tool when you need to have more information. So utilizing that and providing education through technology is, I think, a very innovative approach to the developing world.
Thank you.
Could I just jump in? I just wanted to, I'm glad you brought that up, because the same technology, the same group is also doing that with tuberculosis, diagnostic, and treatment management, both for drug-sensitive and drug-resistant TB. So it's a great example, and it's being used and very accepted in India, and also then therefore very useful for, you know, global learning. That's another way in which that technology is going back and forth.
Thank you. Thanks for that. I was wondering if I could ask the panel a broad question on partnerships, as that's the sort of unifying theme of this discussion, and that's perhaps you could identify what are sort of the barriers to partnerships in the various areas that you're operating in on health. I mean, for example, I can't have you here on the platform, Betty, without asking about some of the barriers to building partnerships in the life sciences sector. You know, how are, for example, the intellectual property regulations, rights in India affecting your ability to forge partnerships? Or maybe, you know, to use a more recent example as well, the price controls that are being put on not only medicines but medical devices like cardiac stents. But maybe, you know, from our USAID and CDC representatives as well, what are the biggest challenges that you encounter in building effective partnerships and are expanding or deepening your health partnerships in India?
I think that things have only gotten better And I think there was a lot more barriers in the past. I think as time goes on, truly forming a private-public partnership, it's only going to get better because I think there's been more transparency, more knowledge. Let's move forward and do this. I mean, everybody has their role to play, and it's critical to have all the players there to contribute to it. I think that it's evolving into the US medical healthcare system as well, where you can't operate in silos. I think that pharmaceutical companies have to find innovative solutions with the government to make healthcare affordable. So I think that the public health aspect considerations that we used to not think about is actually, we've done it in our group for a while. I find that for the US and Europe, my colleagues are also thinking of this, value propositions, transparency finding. So I think that this is what, life never stays the same, and you have to evolve to meet the needs of what is expected, and I think everybody expects to have good health care. So not only Americans, Europeans, everywhere around the world, and that's a global responsibility.
Thank you. Nanda, do you want to give your perspective on this?
I actually, I think I concur that what one is observing is it's becoming, as countries get more dynamic, right, and as you have more touch points to build partnerships, it becomes much easier to build those partnerships, right? And quite honestly, in the example that I was just walking through, we've run into absolutely no difficulties, right? And the interesting thing here is that one of the biggest things we can do, when you talk about partnerships, is de-risking investments, right? Because we want the primary healthcare market to work. And there's a very interesting instrument we use called the DCA, which is a credit guarantee that the US government can make available. What it brings is the commitment of the US government to a lender, right? Which says that if this loan goes belly up, correct, we will cover 50% of that. We de-risk it. And for us, in the Indian context, to buy this, we did one thing we made available $10 million in private equity investment. It cost the US government only $40,000 to de-risk this. That's because of the power of the US economy that we can bring to the table, correct, to de-risk this investment. When we go and say, we want you to put money in and we are willing to take part of the risk, you can open up a lot of markets. So I think there is a lot of interest in looking at how we can bring some of our strengths, right, to bring some of these interesting partnerships to work. So we are finding more and more interest in these partnerships. And I think, quite honestly, as you were rightly mentioning, systems change, countries change, everyone has to adapt. But there's only greater interest in this and less. And we have one of our public-private partnership experts sitting at the back. Would you like to add something to what I just said?
Thank you.
Please.
Here you are. Putting you on the spot here.
In some ways, yeah.
Yeah, no.
In some ways, I think the barriers are us. I think for USAID, it's not easy for us to change our processes and our mindsets. And I think there are a lot of people that are willing to do that, but trying to figure out. I was just in India, and I was saying, people are so busy with administrative work that they can't get out of the building. So how could we go talk to Gilead or, to other partners? And so kind of retooling our incentives for our staff in terms of what is expected of them and how to engage with the private sector is something that we're working on.
Thank you.
Thank
Kyla,
you.
Thank you for that. Kyla, would you like to add something?
Sure. I think the one thing is that it takes time and it takes building strong relationships. And so I think one barrier is just that if we can't keep doing it, then it's really hard to make progress. So I think one is just those relationships. I also think that with uncovering, say, a laboratory that isn't as strong as it could be, or diagnostics that aren't there, or better outbreak investigations, there's some risk that you're showing, some gaps and deficiencies. And so I think that kind of circles back to why the relationships have to be so strong, and there has to be quite a bit of trust that, we're working together to build a system, and the system isn't perfect. It isn't perfect anywhere. And so that takes time, but I think there has been really great progress in the last year and a half, and I think it is, only going faster and getting better and getting stronger as we keep building upon it. But it is fragile at all times, and I think it has to be, cared for. And with that, then the barriers kind of slip away.
Mm-hmm. Thank you. Well, we just about have time for maybe one or two more questions. So if anyone has someone, this is your last chance. Why not have a second go? Why not? Your hand was up first.
You all mentioned mentoring and how mentoring seems to be evolving with your partners, and how the transfer of technical knowledge is not just bringing new knowledge, it's really transferring so the country takes ownership. So I was wondering if you could talk about some effective practices, models of mentoring that have worked. Thank you.
Maybe I could add a question to that as well for you, and that's what's your assessment of India's capacity and expanding India's capacity to mentor others? So I'm thinking of sort of three-way partnerships now. Obviously, Gilead, you've talked about those partnerships in India and how they've had sort of global repercussions. But as India, becomes a more vocal player on global health, becomes a sort of a net development actor, and as a developing country has a lot of lessons presumably to pass on to other settings around the world. Perhaps you could talk a little bit about India's mentoring capacity as well. So, two questions in one there.
So for me, I'm always interested in building capacity in country. It's much more sustainable. They're there every day, 365 days, and they're there and they're invested in their own country. Initially, when we did programs years ago, we still do. We bring experts to come to the country. But oftentimes, I hear from the experts, they get so much more out of this sometimes. It's a two-way street because they're practicing medicine with all facilities and state-of-the-art equipment. They come and they see the scenarios where you may not have everything that you wish for, and they still provide good care. I think that the strength is building understanding, going into these countries with open eyes and respecting their infrastructure of what they have, and not criticizing or using your perspective, but just to understand theirs and then help them supplement to improve things. So I think that practicing medicine in resource-limited setting is far more difficult than practicing medicine when you have all the equipment there. And so there's a lot of great lessons to be learned. So we oftentimes support innovative groups who've done great and bring them to other developing countries and to share there because it's very similar. An example is Asia with hepatitis B. They could be bringing their knowledge and treatment because it's more practical for someone in Africa who has similar situations where they may not have the reference laboratories or able to get RNA levels for diagnostic tests. Their scenario is much more similar to Asia than it is to the US. So that's, I think, enhancing that and bringing education locally is much more sustainable.
Thank you.
I think that's a great question, right? So I think the short answer is, I think India has already does and has a tremendous capacity, right, to mentor others. And if you take the RSBY scheme, and as part of that, they had this very interesting way of how do you get these ID cards, correct? And how do you do biometric ID cards? I mean, that's something that a lot of other countries are going to India to learn about. So India is already doing this knowledge transfer on its own, correct? One of the things, to second your point, when we started doing this intervention, we actually found that as USAID, we had to first engage with domestic partners, because we don't go and implement, right? We implement through what we call our implementing partners. But we had to use implementing partners that were both local and had the technical expertise to do this, right? So the interesting thing is that there's a huge Indian diaspora that has actually gone back, which has got a lot of this expertise. And the person who directs this, the implementing partner is local, but the person who heads up this effort for us through our implementing partner used to work on Wall Street. He had gone back to India and set up the first private health equity fund for India, right? And so it is, for this individual, the mentoring, it is not about the money, right? I mean, he's made enough money already. It's about making change. And getting such people to come in and act as the change agents and as the mentors, right, is extremely effective because they understand the context, but they also have the technical expertise and they are able to transfer knowledge more effectively. So I think that has been one of the reasons why we've been as successful as we have. And the one thing I found in the health sector in India is the most innovative solutions in the health sector quite often are coming from people who were never involved in the health sector. So if you look at one of the very interesting innovations that are taking place, it actually is somebody who was a Harvard Business School graduate who worked for Bain Capital, went and set up Bain Capital's office in India, and now is setting up primary healthcare networks, right? The other person who got involved in trying to build capacity for getting these entrepreneurs to scale actually is a Stanford MBA who said, how do I apply this to health? The other person worked for McKinsey, who is an engineer from one of the IITs in India, who's trying to solve the peri-urban health problem in Mumbai. So I think what we need to do is to see where the innovators are, and quite often when we are within the system, it's hard for us to innovate. And some of the innovations are actually coming from outside the system. And as donors, I think we have to be proactive in identifying these change agents and these innovators and going behind them. And that means that we have to get out of our comfort zone sometimes.
Thank you. Well, Kylo, we've kept you incredibly late there in India, so we should at least give you the final word. So do you have anything to add on this question of mentoring?
Sure. I mean, I think that one of CDC's signature efforts globally is capacity building and mentoring and working, especially the EIS program, which really is very hands-on, field-based, do one, see one, do one, teach one kind of mentorship. And it really works. And between the EIS program in India, the other epidemiology training, AMR, tuberculosis, all of it, we've probably trained hundreds of individuals who are now training others in these programs. So it's a key part of global health security everywhere, and especially in India. And I absolutely think that that India can and wants to be mentoring, certainly in the Southeast Asian region, as well as globally. And I think we saw actually a lot of the Indian mentorship in the Ebola outbreak of Sierra Leone. There was a lot of interchange that way, so through WHO. So I think that's a really important area, and one that is certainly fundamental to global health security succeeding in India and anywhere.
Well, thank you. Thanks for your contributions. Thanks for sounding amazingly awake, considering what time it is over there. But I really want to thank you all for great questions and a great discussion today. And thanks especially to Dr. Lassason, Dr. Nandakumar, and Dr. Chang for being with us today. And please join me in thanking them.
Thank you.
Thank you very much. Please read the report and offer feedback as and when you're able. Thank you very much.
Okay, thank you. Bye.